All right. Good morning, everyone. See, we have a full house here. I think we just give people just a minute more. Oh, it's already 10:31. Let's say 10:32 for a couple of people to join, and then we can just get started once it's 10:32. Our elder is on the call. Elder Amel, are you on the call? I'm just checking if Elder Amel is on the call. Okay, I do not think so. Let me just quickly troubleshoot and see if Elder is able to join the call, and then we can get started. Just trying to get hold of someone to see if Elder Emil is able to join the call. He had said he was available to join the call. Just looking at our time is already 10:33. Is there anyone that is willing to start us up with an opening prayer this morning?
Hello.
Hi, Elder. Good morning.
Yeah, struggling with this thing a bit here.
Right.
Finally got to.
Awesome.
Okay.
That is good.
Good morning.
Thank you so much, Elder. Good morning. How are you doing today?
Oh, very good, very good.
Awesome.
Got a little busy this morning.
Right. But the weather is beautiful.
Thank you.
Okay. So we are going to start our in-service training with an opening prayer by our Elder Emil Iwe. So Elder, over to you. Are you able to start us up with an opening prayer and word of wisdom? Thank you.
Okay, just go ahead with a prayer.
Yes, please.
Okay, thank you. Good morning to everybody. I just sitting here thinking about how valuable it is to have opening prayers and closing prayers at these meetings. It remembers our and acknowledges our culture and our ancestors. Every meeting was very important. It was a way of showing respect to the people in the meeting and encouraging them to have clear minds, clear hearts. And each meeting was usually opened with a prayer and a drum song in some instances. So it's a means of acknowledging our past, and I think that's so important. The Cree language is getting lost. This generation disappears, and it's going to get harder to maintain our languages. So I want to thank whoever instituted this, brought this back of opening prayers and so on. I know people are busy. You want to get to the next meeting, and especially lawyers in the boardroom, they start looking at their watches when there's going to be an opening prayer. So, but anyway, good morning to everybody, and I wish you have a good day. And I want to say a prayer by Black Elk. Hello? Grandfather, Great Spirit, once again behold me on earth and lean to hear my feeble voice. You lived first, and you are older than all need, older than all prayer. All things belongs to you. The two-legged, the four-legged, the wings of the air, and all green things that live. You have set the powers of the four quarters of the earth to cross each other. You have made me cross the good road and road of difficulties, and where they cross, that place is holy. Day in, day out, forevermore. You are the life of things. Hi. Thank you very much, Grace.
Thank you very much, Elder. We always appreciate having you in our calls and our meetings, and we always look forward to getting those prayers and word of wisdom that keeps us going for the rest of the day. So we appreciate all of your commitment to our organization, and we say thank you again. Okay, so good morning, everyone. Thank you so much for being able to join this very important call. We thought it was very important, essential to put this together, considering the current landscape that we are in, particularly with the new therapies that came on board in the last few weeks, which is the monoclonal antibody and the antiviral. And having said that before I continue, I'd like to acknowledge that we are taking this meeting from the 36th territory, the traditional territory of the Cree people, and the homeland of the Métis, and we pay our utmost respect to the First Nation and Métis ancestors of this place. We reaffirm our relationship with one another. Just a form of opening remarks. Again, welcome. Thank you so much for setting this time aside out of your very busy schedule, and as much as possible, we'll try to work within time. We know people are very busy at this time, but the major reason for this in-service is to get our able Katie to take our nurses through what they should know, the important points that's worth knowing for prescribing the monoclonal antibody and the oral antiviral meds in our native communities. We know we do have our SHA colleagues, some of our SHA colleagues on the call as well, and we welcome you on the call. We always work definitely collaboratively with each other to ensure our community members are safe and secure, particularly during the pandemic. A few housekeeping, we are recording this session for people that probably might not be able to join, because we know people are busy in the clinic as well. And so we would like you to please mute your mic just so there's no distraction, there's no background noise while we are taking this training. So for others, they will have a clear recording after now. And we will post that recording on our website after this training this morning. Other than that, Katie Catherine Wendell is our regional pharmacist working with the Indigenous Services Canada. Catherine will be taking us to the number 3 agenda item, which is the monoclonal antibody, the antiviral and Saskatchewan current approach to these treatments. And so she'll be going through that. And after which we're going to have the Q&A session, which will be the number 4.
Line 3.
Deb, can you please mute your mic? Thank you. And then we'll have the Q&A sessions, and whereby everybody is free to ask any questions. And I believe you can always still post questions after today, because some questions probably won't come readily, but yeah, you can always send us questions after today, and then we'll provide the answer as appropriate. And then the last item there will be closing remarks, and that will be about MHO, Dr. Naboka, and he will then round up all of our conversation for this morning. Just in the interest of our time, because we are pretty much behind schedule, I will hand the call over to Katie, so we can just get over to the main item for today. Thank you.
There we go. I couldn't find the unmute button after I shared my screen. I'm sorry about that. Thanks so much, Grace. Thanks, Elder, for that prayer. I really appreciate that this morning. I am south. I'm in Treaty 4 territory this morning, but I'm happy to be with you today to share some of the information around these new treatment options, especially, you know, nurses up north. You play a huge role in the healthcare of people up there. And it's really good to have the background knowledge, not only if you're going to be administrating these medications or dispensing them in some situations, but you know, that check on that healthcare team is really, really important. So if you have any questions, of course, please feel free to put them in the chat or raise your hand. I will try my best to answer for you. So today, basically, we'll talk about the outpatient management of patients diagnosed with COVID-19. For the most part, patients are not can be managed outside of hospitalized settings, and so with the 2 drugs that we have, sotrovimab and the Paxlovid, these 2 medications can significantly reduce that disease progression to hospitalization or death. These agents really do have to be initiated as soon as possible after someone becomes symptomatic, typically within 5 days of onset. Sotrovimab is a little bit longer, but something to keep in mind, the earlier the better for us to get those patients on these medications. And a reminder, treatment is really no substitute for vaccines.
Katie, we're losing you there. I don't know if that was just me.
Yeah, Katie, we lost you a bit
Oh,
there
there we
due to
go. I
network
came back
issues.
now. I'm
Sorry for that.
sorry.
Yeah. Thank you.
Can you hear me now?
Yes, we can
Are we
hear
Yes,
you.
we can.
Okay, sorry about that. It must have been my connection. I think I lost you guys maybe on the days of, you know, initiating this therapy. Should be initiated as soon as possible for both of them. And of course, the treatment is no substitute for vaccination. Vaccines are our most safe and effective way to combat COVID-19. Let's see. So the first one we have is sotrovimab. Sotrovimab is what we call a monoclonal antibody. Basically, what it does is it gives your body the antibodies to attack the COVID-19 virus. So if someone is unvaccinated, or if they have a compromised immune system, either acquired or medication induced, those kinds of things, sotrovimab will boost the body's capability of fighting off the infection. So the earlier the better. It gives the body a head start in battling that infection. So Health Canada has approved sotrovimab for adults and adolescents 12 years age and above. But here in Saskatchewan, we are going with the adults for administration. Sotrovimab is not authorized for patients who are in a hospitalized setting. It's really for mild to moderate COVID, and those patients who have oxygen to help them breathe. So if their oxygen stats are low and they have supplemental oxygen, sotrovimab hasn't been really found to be effective. So most effective in those that are not hospitalized and not requiring additional oxygen. Here in Saskatchewan, our eligibility is a little bit different than what was in those studies that it was that the drugs were studied. But here, high risk, or patients who are at high risk of disease progression. So anyone who's 55 years or older, irrespective of comorbidities. For people that are younger, between ages of 18 and 55, basically their eligibility has to be they've tested positive, of course, right? And they're symptomatic. Do they have one of these other issues? So things like diabetes increases the risk, obesity, chronic kidney disease, congestive heart failure, COPD, asthma, moderate to severe. So this is actually defined in the eligibility around, has that patient had a corticosteroid, an inhaled steroid in the last year or so, so asthma that is requiring treatment. And then, of course, immunocompromised. And like I said before, if that's medication induced or acquired, either or are eligible for this treatment. And of course, transplant patients, regardless of their vaccination status. So the last 2 points, even if they have a full course of vaccines, which is defined as the 2-dose series, they are eligible under the Saskatchewan program for these medications. Of course, go and check that current directive. We are working in such a changing environment. Always make sure you're using the most up-to-date directives for your facility. So sotrovimab, that monoclonal antibody, it is an IV infusion, and I'll cover that a little bit later. But really, what I wanted to show you was the evidence that we have for treatment. So this is a study. It's a smaller study. Only 868 patients were used. So half got sotrovimab, half got placebo. The most common adverse effect was diarrhea, and that only occurred in just over 1% of patients. So that's the most common side effect. There are a few other ones to think about, but they have to do with infusion related reactions, right? And of course, possibility of anaphylaxis. With anything that we inject, we always have to be on the ball for that. So when they looked at the evidence for using this medication, it was based on the progression of COVID-19 defined by hospitalization for greater than 24 hours. that really needed treatment in the hospital, and so management within the hospital or death from any cause at day 29. And what they found was, you know, in the placebo group, there was 21 people that were either hospitalized or passed away, and only 3 in the sotrovimab arm. So the risk reduction that they calculated was an 85% risk reduction. So if you think about this in terms as your patients up north, a possibility is, you know, they might not have to get medevac, they might not have to go to a hospital, because if they get this treatment early enough, it could decrease that incidence of those risks. There was 1 death in the study, and it did occur in the placebo arm. So sotrovimab, like I said, it is an IV. So that is the drawback on this medication. It can only be given IV. So it does need to be diluted prior to administration. There's no reconstitution, just a dilution. Basically, take out the vial from the fridge, allow it to come to room temperature, take a look at it, make sure it looks appropriate. It's usually clear, maybe a little bit of yellow or brownness to it. 8 mils is the dose. So 8 mils is 500 milligrams of sotrovimab. And that is put into a mini bag of either normal saline or dextrose. So those are the only 2 IV solutions that it has been found to be compatible with. Of course, you know, you always want to label that with the time that you mixed it up as well, just in case you can't use it right away and you can use it later. There is some stability evidence for that. You don't want to shake even the vial. So the vial and the mini bags, don't shake it vigorously. Just give it a light rock back and forth a few times, and then administer that medication. So sotrovimab is a 500 milligram dose, typically in a 100 mil mini bag, infused over an hour. So while it's being infused, things to watch for with any infusion, of course, right? We always watch for those infusion-related reactions, possible anaphylaxis. There was 1 anaphylaxis case that has been reported. It was treated successfully with epi, and further complications were avoided. And then for monitoring after that infusion, it's usually about an hour afterwards. Keep monitoring them for any signs or symptoms of anaphylaxis, but otherwise it's quite well tolerated. Just that diarrhea side effect. And of course, you know, with diarrhea, it can also be a symptom of COVID. So it's one of those things to think about as well. So sotrovimab is stored in the refrigerator between 2 to 8 degrees. It has to be protected from light, and don't freeze it. It is compatible with normal saline and dextrose. It isn't compatible with any other infusion, so it has to be done by itself. Stability after it's diluted. So if you do mix up that bag and all of a sudden for some reason you can't use it for that patient, it can be refrigerated for up to 24 hours or even stored at room temperature for 6 hours after it's been diluted. So sotrovimab is relatively safe and effective. It's a 1-dose type of medication. The cons, of course, right? It's an IV administered drug, so it does take healthcare resources and clinic space to do, especially if you have a COVID positive patient, right? Keeping those infection prevention and control practices in place is really important for this one, but it is a good option, especially when the oral antiviral is not an option, and you'll see why in just a little bit here. So the oral antiviral that we have that has been approved by Health Canada just, I think, last Monday, it's all a blur right now. So Paxlovid has two drugs in it, Nirmatrelvir. Nirmatrelvir is the actual drug that it blocks the replication of the virus. So that is how that one works. There's another portion of that drug, and it's ritonavir, and people might be familiar with that with HIV type treatments and those kinds of things. But ritonavir, what it does is it actually is there to decrease the metabolism of the other medication, nirmatrelvir. So the nirmatrelvir is the active one. The ritonavir is the one that slows down the metabolism of that and keeps it active for longer periods of time. So that combination of therapy is expected to be effective against the Omicron version. Same with sotrovimab has retained its effectiveness with that variant. And just like sotrovimab, Paxlovid is not used for hospitalized patients. It's not authorized for pre-exposure or post-exposure prophylaxis. There is ongoing studies, so more to follow with that, but as of right now, it is not approved for use, and it should only be used for that 5 days of treatment. So Paxlovid, when it comes in these daily packets. And you'll see the two kind of pink tablets there are the nirmatrelvir, the 150 milligram tablets, and normal dose is 300. So people have to take 2 of those along with the 1 dose of ritonavir. So the ritonavir is the white packet. With this medication, people with kidney function, there has to be a reduced dose. And so this is where we're running into some things regarding dispensing. So it's really important that if a patient has reduced kidney function, GFR of 30 to 59 mils per min, really we do need to reduce the dose of nirmatrelvir. And if you take a look at this picture just to the right, it has the 2 doses there circled. So those are the 2 that would be removed from the packet. And I'm not sure if these stickers came with this. This might be a question for you, Grace and Carrie, is do we have these moderate renal impairment dosing stickers if it came with the product or not? And if it didn't come with the product, we could order those. So that sticker goes over top of those 2 doses that are removed for renal failure patient or reduced renal function patients. So there is a reduction of dose for those patients. Paxlovid, of course, sometimes it's hard to remember to take meds regularly. So some kind of reminder on a phone, those kinds of things are really good reminders for people, especially with this one, to take it twice a day, have a reminder on their phone or those kinds of things. Of course, if someone has missed a dose and it's within, the 8-hour kind of time frame, that patient can take that forgotten dose. If the patient has missed it by more than 8 hours, they shouldn't take that dose. They should just start over again, basically continuing on their therapy when they were supposed to regularly take their next dose. And don't double up to make up for those missed doses. Here is the big one. Paxlovid is plagued with drug interactions. So the ritonavir that I was chatting about earlier, that decreases the metabolism of the other medication, nirmatrelvir. That one also causes a lot of interactions with other drugs. So co-administration with this and other drugs can be a risk and can be a significant risk for some people, depending on the medication that they might already be on. So there is a really low threshold right now for our prescribers for drug interactions. So if they can't be mitigated, typically the prescriber will just go over to sotrovimab. So things to watch out for, I guess, medications that could be elevated by this drug therapy, there's a list, and other things that someone might be taking can increase or lose the effectiveness of the drugs. So this is not an exhaustive list. There's actually a list of drug interactions on the product monograph right now. There's also some drug interaction checkers that we could use to check those drug interactions. But just to be aware that there can be serious adverse effects for people if they are taking other medications that they don't disclose, if they're taking it unprescribed to themselves, if they're sharing of medications. So we really have to make sure to tell people that this is prescribed for you. Continue to take your 5-day course until it's completed. If you have any side effects or issues, please contact, the nurse or the pharmacist or healthcare provider. Some other considerations we have with Paxlovid is oral contraceptives. Their effectiveness can be reduced. Thanks, Marina. Oral contraceptive effectiveness can be reduced with Paxlovid. So if you have someone of childbearing age, they're using oral contraceptives, a barrier method should be added. Those kinds of things to keep in mind. Pregnancy is not approved. Breastfeeding, we don't know the drug, how much is excreted in drug milk or in breast milk, excuse me. And so, we want to stay away from pregnancy or breastfeeding as much as possible. Another interesting thing to think about is for patients that are not diagnosed with HIV or undiagnosed or uncontrolled HIV status, we don't really want to use these medications because there is a potential risk to develop resistance to protease inhibitors in these individuals. So typically, if they haven't been diagnosed or it's not controlled, they wouldn't be treated with Paxlovid. We would go to sotrovimab. If it is being treated, their viral load is low, they're doing well, they could still get Paxlovid, and there's no dosing adjustments that are needed for that. So adverse effects for Paxlovid, the most common is a taste disorder. So if you take a look at the clinical trial here, we had about 5.6% of patients had a taste disorder. And the other common one is diarrhea. So those were the two most common side effects outside of those drug interactions, of course. And one thing to think about for both of these medications is because they're so new, we don't have all of the information that we need that we do get for drugs that have been on the market for many years. So if you're a patient or if you're a healthcare provider, it's really important to report suspected side effects to Health Canada. You can do this online to report those side effects, but it's a really good thing to have for post-consumer, after it's going out in the market, to really have a good firm understanding of the potential adverse effects that these drugs can have. Paxlovid, although it's a tablet, it is still temperature sensitive. So it should be stored at room temperature between 15 and 30 degrees. So if you're going to drop it off at someone's house, don't leave it in their mailbox because it can freeze. This stability data actually has come from Pfizer in particular. It's not published in the monograph, but we did go directly to Pfizer to see if they had additional stability information, which they did. So between 2 and 15 degrees, it says not more than 14 days, and less than 2 degrees, not more than 7. So the effects of -40 on this drug are really unknown. So something to keep in mind, keep it at room temperature as much as possible. The evidence for Paxlovid. So this is an interesting spot. So as a healthcare provider, when you take a look at the evidence, sometimes it doesn't stack up. Right now, Paxlovid is, the evidence isn't published. So it's non-published data. I don't know if they're planning on publishing it. So that makes a difference right off the bat. So the first evidence that we have is in this EPIC evaluation protease inhibition for COVID-19 in high-risk patients. So that one was done with 2,200 patients, quite a bit more than the sotrovimab study, so 2,000 patients. And what they did is they took a look. So if Paxlovid was administered within 3 days of symptom onset, they took a look at how much of the risk was reduced of hospitalization or death within 28 days. And so that risk reduction was 89% in that study. Results were actually similar when the drug was taken within 5 days of symptom onset. It was just slightly reduced. I think it was an 85% off the top of my head. All of the deaths that occurred did occur in the placebo group. There was no increase in drug-related adverse effects compared to placebo. I'm sure they checked for those with the trial. But here's the other interesting part. The other study that has been, and these studies are ongoing, so the EPIC SR, so standard risk patients, this study is in, or the evaluation is of 991 patients who were either unvaccinated or vaccinated. And when they compared that to placebo, there wasn't a statistical difference between the two arms. So right now we do see there is a benefit for those people who are unvaccinated, and we get them on these medications right away. We're not really sure yet if vaccinated folks will have the same benefits as unvaccinated. So something to keep in mind there. And of course, it's unpublished data. It hasn't been peer reviewed and those kinds of things. So Paxlovid, really patients should only receive a 5-day course of therapy. They shouldn't get additional therapy. It should be started within 5 days. Remind patients of that importance to take both of those medications together. So both of those pink tablets and that white tablet at the same time. So morning and night. So take all three at the same time. If they do have renal impairment and they are on a reduced dosing schedule, they take 2 tablets, 2 in the morning, 2 in the evening. And of course, watch for those drug interactions. Currently, Paxlovid is only recommended for adults in Saskatchewan who are symptomatic and they test positive, of course. So regardless of their if they are immunocompromised, regardless of their vaccine status, they can be eligible if they're over 55, just like the sotrovimab, and not fully vaccinated, they would be eligible and have a medical condition that puts them at high risk. Right now in Saskatchewan, typically these 2 drugs are accessed through the 811 health line. So if patients are feeling as though, number one, they have a rapid test at home, perhaps they have symptoms, they call 811. 811 has the ability to set them up with the COVID response center, and physicians out of that center will prescribe the drug. For the North, we are still working on a plan for that. Of course, you know, the North is special, so we want to make sure that patients are able to access those medications as well. And so we are working on a more formalized approach for the North. Really keep in mind, these are really rapidly evolving treatments. Always check for updates. Always look for the SHA most up-to-date drug information sheets, those kinds of things. Currently, the only treatment that we have available is the sotrovimab and the Paxlovid. There are other monoclonal antibodies, other oral antivirals that are out there. They haven't been approved by Health Canada as of yet. And these are the 2 treatments that we have. obviously has identified that eligibility criteria for now. Only specific prescribers can authorize the use, and that's really to keep in mind all of those side effects and all of the potential issues that arise around the oral antiviral. Of course, if someone is not eligible for Paxlovid, they could possibly be eligible for sotrovimab. Vaccination is still the most effective, safe and effective way to prevent and minimize the harm of COVID-19. And the treatment is not a substitute for vaccines. And I think as healthcare providers, that is one of the points that we really need to get out there to talk to people about. There are risks with these other medications, and the best thing to do is to get your vaccine. All right. I saw there was some comments in the chat as I was going along, so I'll take a look at those if I can. Goodness.
I have to look for you, Katie.
Yeah, thanks, Grace. So if anybody ever wants to contact me about drug questions, those kinds of things, please feel free. I am here to support all of Saskatchewan region as the regional pharmacist. I can help so just flip me an email if you need additional support. I add a caveat to that. I am scheduled to be on vacation after this week. So after this week, I'll be heading down south for a couple weeks, but I'll be back mid-February.
Awesome. Thank you so very much, Katie, for again your time and for being able to walk us through these two very important meds at this time of the pandemic. That was a very great presentation. You will agree with me. A lot of information. The good thing is that we have the PowerPoint slide. We can always go back for reference. So at this point, I believe it's time for Q&A. But before we get to the Q&A, I lent you out the host function. Are you able to display the agenda, please? Okay, thank you. I got a pack of the Paxlovid. This is what it looks like. We're going to set that out.
Perfect.
And then we have 5 of this. So we have 5 with the morning and the afternoon. Sorry, morning and the evening doses clearly labeled there. However, we don't have that sticky you did mention earlier. So for all of the 5, they're all like this, but there is no sticker on any of them. So will that be coming from you? Are you able to ask for?
Yeah, I think we could order them through ISMP Canada. So I'll just take a look and I'll look into that for you, Grace.
Okay, awesome. Thank you very much. And again, just a comment that where you did mention about the NOT. So for the NOT, it will be business as usual. We are hoping to get this meds to our primary care centers majorly. And so it wouldn't be 811 for us. Preferably, we want community members to call into those clinics, and then they can tell them what to do and what the process will look like at that particular point in time. So that is the uniqueness of our little communities. Okay, so up onto the floor. I don't know if you have any questions for Katie. She's here with us today. Any question is acceptable.
I see there's one in the chat. The question is, were there any other studies done on fully vaccinated people? And those studies are ongoing right now. Even the ones that are for people that have been fully vaccinated, these studies aren't complete. They are ongoing. So we will have more information as it goes. These 2 drugs were approved under an interim order under Health Canada with the data that was submitted to them. So, you know, that information will be coming, and hopefully we'll see if there is a benefit for vaccinated folks to also get that treatment option if they are positive and symptomatic or not symptomatic. There's also studies going on using Paxlovid for exposure, so prophylactic for, say, if someone in the house has tested positive but others haven't. That information is still being studied, and we don't know those answers yet.
Awesome. Thank you very much, Katie. Do we have any questions for Katie, any question at all is welcome at this point. Such a quiet audience today.
Yeah, I know, right? Usually I get more than this.
Right.
I saw some familiar names on there, so hi everyone. I miss coming out and seeing you.
All right. So I got this coming from Tara Lights and Roder. Claudia said, "Oh, slides show very clear." So it shows. I think you did work out the work on the slide, so we can all go on with that. Um, But in the absence of any questions, again, please feel free to ask any question at any point. We know questions will keep coming as we get to use this met. A lot of questions, a lot of clarification. And so please happy to support us with that. And please feel free to reach out to either ourselves or even the public health unit here at NITA office. We are definitely very available to support you with this new addition to the pandemic as we move along. I'm hearing a question. Dr. Ndubuka, would you like to give an closing remark or any comments before we call it a day?
Yeah, thank you so much, Kathy. And this has been an excellent presentation. You really broke it down to the basics, very easy to understand, and I appreciate all the information that you've brought to our Northern community teams. And we also want to appreciate the participants today for making our time to attend this very preliminary presentation, which I believe will go a long way in preparing our communities to, get this rolled out. I know some of the questions that might still be at the back of our minds would be around distribution, prescribing, who does it, who does not, who's eligible as a prescriber. I think those details have been flushed out as we speak, so just watch out for those. For now, we do know that based on what has been advised from its headquarters for nursing stations, only physicians and NPs are able to prescribe at this point, but other details will follow for our Northern communities as to how or what the implication would be. And we will also continue to work with our SHA counterparts, including the pharmacists, to ensure that we have a seamless approach to distributing, dispensing, and ensuring access to individuals that need them. Again, be mindful that when you look at the eligibility criteria that Kathy displayed, in terms of the population 18 plus with underlying medical condition, I think that goes to say that a significant proportion of our population in North will be eligible for that. So thank you again for participating, and we will keep in touch with you. There might be another communication that will be going out from Grace later today to NICs. Please watch out for that and kindly respond. That would have to do with the prescribers potentially within your area. So that will help us to respond to some of the questions coming from the ministry. Again, thank you all for participating. I will hand back over to Grace, and then the elder can close us off in prayers. Thank you.
Thank you very much, Dr. Buka, for those comments. Having said that, I don't think I have any other thing to say right now. I think we have a couple of minutes back into our day that we can always make do with. But again, some additional communication will be coming out of our office here with regards to these new meds as we move along with the rollout. So thank you, Katie. Thank you for your time. Thank you for the very great presentation. And to all of our participants, we do appreciate your participation on this call this morning. Elder Emil, are you still on the call with us? Elder Emil, are you still on the call? I don't think Elder is still on the call with us. In the absence of Elder, is there anybody that is happy to give us a closing prayer? think I'll probably just do that, volunteer. So Father, we thank you for today. Thank you for the great presentation that we had in the last few minutes. And our prayer is as we've come together as the healthcare worker, you give us the wisdom and the strength to roll out this medication, as it will be helpful for our population and the communities that we serve. We ask for your strength even as we carry on during this pandemic, knowing that a lot of us are getting tired, but we do ask for your strength and we do ask for your guidance and wisdom as we go along during this pandemic. In Jesus' name I've prayed. Okay, so thank you everyone. Have a great rest of your Wednesday and stay safe.